Welcome back to OpenLine tonight. We are talking about breast cancer. It is Breast Cancer Awareness Month. If you have a question about breast cancer, Dr. Abramson from Vanderbilt is here to answer that question for you tonight. Go ahead and give us a call, 615-737-PLUS. Amanda, we thank you for calling earlier. It's a great question. I do want to talk about the different types of breast cancer, and you mentioned the triple negative breast cancer, that this is one of the more aggressive forms. Can you explain more to me about that?
Yes, so triple negative breast cancer basically is about 15 to 20% of breast cancers, and we really just don't know how to characterize them. We don't have a target. There was actually a wonderful study that came out of Vanderbilt. Dr. Jennifer Pietenpol, who's the director of the Cancer Center, her laboratory actually subtyped triple negative breast cancer into 6 distinct subtypes.
Oh, wow.
So what they did was really different from what had been done previously. Previously, everyone was trying to find the one common denominator in triple negative breast cancers. And what her laboratory and what she said was, perhaps there isn't one. Perhaps they're just different diseases. And it turns out they were right. So we have these 6 distinct subtypes of what we're calling triple negative breast cancer. They basically have different characteristics, and the lab is now working on refining those, probably down to more like 4 different types of triple negative breast cancer. One of those subtypes is the androgen receptor positive triple negative breast cancer subtype.
What does that mean?
So that subtype, basically it means that much like the estrogen receptor, this little group of breast cancers actually has the androgen receptor, which is what testosterone normally binds to.
Gotcha.
And it actually acts a lot more like estrogen receptor positive breast cancer than like triple negative breast cancer. It's a little more slower growing. It just has different characteristics, and which is really exciting. That we might be able to take a little sliver of that triple negative breast cancer and break it off and call it positive for something, call it androgen receptor positive, and potentially target it. So we've actually started a clinical trial at Vanderbilt where it's actually available at 15 centers around the country, where we're actually targeting androgen receptor positive triple negative breast cancer with a drug called enzalutamide, and it's a drug that's actually used for prostate cancer.
Oh,
so
wow.
It's pretty remarkable. And you know, so we're taking that one little sliver, we're looking at the other subtypes and trying to see, are there particular things that we can do with some of the other subtypes that might be different and potentially help that specific group of patients.
Now that you have this information on the different subtypes, and okay, this one may respond to this drug better, that one may respond to this drug better, and you have these clinical trials, when you have a patient come in with this type of cancer, do you say, let's do the normal chemo radiation and see how that goes? Or would you say, what about this clinical trial? Like from the get-go, would you start with that?
Potentially. So clinical trials are a little bit tricky. First of all, just in terms of defining what a clinical trial is, it's a research study that's designed to test a new drug, a new device, anything. Clinical trials in general are there to help the patient, especially in oncology. What we're trying to do is potentially offer a better treatment. But we want to look at the safety of the patient first, and look and make sure that they receive at least the standard of care. So for that particular question, for an androgen receptor positive triple negative breast cancer, if the person presents early, as in they found it on a mammogram, and we would still do the surgery, and post-surgery we would still offer the standard of care treatment that we would normally do. However, if the cancer returned somewhere else in the body, that's when we need to start thinking about other options. At this point, it would be considered metastatic breast cancer. And that's where we would think about, do we want to try a drug like enzalutamide? Could it potentially offer a better treatment, something that's less toxic, more targeted, potentially could work better?
I understand, yeah. Now, if you have this type of breast cancer, any type of breast cancer, you go through the standard of treatment, the chemo, the radiation, whatever it may be, and it comes back. Will it always come back as that same type of cancer?
Not necessarily.
Oh.
Some of these, so one thing to say is if it's breast cancer that has traveled somewhere else, it's still breast cancer. So if it comes back in the liver, it's still breast cancer that metastasized to the liver.
Okay.
It's not a new liver cancer. But it may change. It may no longer be estrogen receptor positive. It may no longer be androgen receptor positive. So we always biopsy to look to see what is it that changed. And it may be that with our treatments, we killed off what we thought was mostly there, whether it be the hormone blockage or whatever it was that we used, and we may have selected for clones that were there that were not like the others, and that's what came back.
Gotcha. Golly, that's why it's so tricky, and there probably is not one set cure, right?
Exactly,
I mean, it just can't be when there's cancer's a tricky disease. Let's go to Thomas. He's on the line. Thomas, thanks for being part of the show tonight. What's your question?
Yes, Dr. Abramson, thank you very much for being on to talk about this important topic. I was wondering if a patient has been successfully treated for breast cancer, other things being equal, what is the likelihood of a reoccurrence? And for a patient who has had breast cancer, are there particular prophylactic measures that you suggest?
Okay, Thomas, thank you very much.
That is a great question. In terms of recurrence of breast cancer, so the great news in the United States today is that 85% of people diagnosed with breast cancer will be cured.
My goodness, that's huge.
That is huge. Yeah. And unfortunately, we really do need to bring that to 100%. But it's still good news. And that number is increasing every year. So if a person is newly diagnosed, we really look at all the different characteristics of their tumor. Are they estrogen receptor positive? Are they HER2 positive? What other things may be driving their tumor? And we look and see, do they need chemotherapy? Do they need more treatment to potentially kill micrometastases or tiny cells that may have gone to other parts of their body? So that's what we would be doing in my office, is figuring out what is the risk of relapse. And that's really the risk of the cancer coming back, or the risk of recurrence. And that's calculated based on the size of the tumor, how many lymph nodes were involved, and is it triple negative, is it HER2 positive? But beyond all of that, what else can someone do to help their chances overall? Yeah. It would be to exercise, 30 minutes a day of walking. It would be to maintain a healthy weight. We've talked about low-fat diets. It's never been quite clear whether a low-fat diet helps or not, but it certainly can't hurt.
Sure.
So that would be another big thing as well.
All right, Thomas, thank you so much for your call. Don's on the line too. Don, thank you for being part of the show tonight. What's your question?
Yes, my question is, first of all, thanks for taking my question.
You're welcome.
I noticed some friends that have breast cancer that have it removed and nothing is done past that. Others have it removed and received a whole battery of treatments. Are there some cancers that never leave the breast and some cancers that do? Could you help us understand that?
Absolutely. Great question. So yes, there are some cancers that are so low risk that it's not worth doing any more treatment. When we think about giving extra treatment like chemotherapy or hormone blockers after the removal of the primary tumor, we really have to think about the risks of the treatment that we're giving, and at times the risks outweigh the benefits. So if your friend may have had a small tumor that was fed by estrogen, just under the microscope, didn't look particularly aggressive, at that point I would have, if that person's risk of this cancer coming back was under 10%, then the risk of the therapy would potentially outweigh the benefit of the therapy. On the other hand, if another friend may have had a larger tumor with multiple lymph nodes involved and a more aggressive subtype, those are the ones in whom we'd recommend more chemotherapy and potentially even radiation therapy as well.
And for the people who may just be able to have it removed, it's a very small risk, do they then need to monitor more often?
No, they do need to continue doing breast exams. They should be seen by a provider every 6 months or so for an exam. But in terms of monitoring with mammograms or MRIs, it's still once a year.
Wow, that's great. Okay, Beverly's on the phone as well. Beverly, thank you for being part of the show. What's your question?
Yes, thanks for taking my question.
Sure.
And I understand that there's not a lot of testing that needs to be done. I am a breast cancer survivor, and my oncotype is like a 15% chance. And I was just curious as to if there's any testing that needs to be done ongoing from here out.
Okay, great question.
Great question.
As far as mammograms or MRIs or anything else.
Sure.
So if the breast was not removed, we do still recommend once a year mammograms, or if needed, this would be a discussion with your physician about whether you would need an MRI yearly, depending on breast density and other factors. But that's really it. There really aren't many other recommendations. And that partially reflects just how many people are expected to do well. We don't look for recurrences because the vast majority of people will actually survive. So there aren't many other things that need to be done.
Let's talk about dense breasts and mammograms. We've heard a lot about that, about maybe they aren't catching them as much, or what's the story with that?
So dense breasts actually independently are a risk factor for breast cancer on their own. And on top of that, mammograms don't basically examine dense breasts as well. So that in itself is a big issue. There are new techniques out there that women can talk to their physicians about. Tomosynthesis is one of them. And that's a way, it's almost like a CT scan of the breast.
Oh, wow, okay.
And that's something that could be considered for somebody with dense breasts.
Is this anybody, would you need to have a family history, or just someone who says, you know, I have dense breasts and I just want to be thorough?
It's more the latter.
Yeah.
It would be a discussion with their physician, and but potentially if they have dense breasts and that's being noted on the mammogram, it's something that could be discussed for sure.
When you have a patient that comes in for the first time, whether they've been referred to you and they know that they have breast cancer, where do you start with them?
When they know that
when they have cancer?
Well, the first discussion I have, and the first thing I want to do, is to reassure them and tell them that for the most part, it is good news. And of course, I'm going to look at the individual person and see where they are. But what we need to first establish for somebody whose cancer was found, let's say on a screening mammogram, is what's the best approach? Should we treat the cancer first, shrink it down, and then go to surgery? Or should we go to surgery first? Because depending on the size of the tumor and depending on other characteristics, we may want to treat it first and shrink it, and then go to surgery. In some patients, we do need to go ahead and do scans, but not all. It's basically people with larger tumors, or if they have clearly lymph nodes involved or other symptoms, we might do CAT scans, but in others, we wouldn't. So we sort of set up an overall plan and then go from there.
Gotcha, gotcha. We have Roxy on the line here. Roxy, what's your question tonight?
Yes, I had breast cancer 16 years ago, and I'm trying to find out. I removed one in 16 years, and one came back a year and a half later. They only done chemotherapy, and they don't do any more checkups. That's because I don't have the breast anymore.
So it's been 16 years now, which is wonderful. So at this point, your risk of the cancer coming back is actually quite low. And depending on the subtype of breast cancer, there may be no chance of it coming back. So triple negative breast cancers, they come back in the first 2 to 3 years, and after 5 to 7 years, if they haven't come back, they're not going to.
Oh, wow, okay.
Now, estrogen receptor positive breast cancers are a different story. They can come back at any point, but really after 10 years, the risk is lower, and the recommendation is still for a yearly breast exam. But they wouldn't necessarily need to do that in the oncologist's office. Their primary care physician could continue with once-a-year exams.
Now, there's also been a lot of talk with if cancer appears in one of your breasts, you know, the question is, do you go ahead and have the double mastectomy, or do you just stick to one? What's your recommendation to patients?
So if there isn't a great reason to have the other breast removed, it becomes a personal choice. From a medical standpoint, having the other breast removed doesn't actually make any difference. It doesn't improve survival unless there's a BRCA mutation or a strong sense that there may be another breast cancer. But you know, it's individual for an individual person. I definitely tell my patients that if you're going to worry about it every single day, and to you it would almost just mentally be easier to have it removed, you might want to consider it, but that's a very personal choice.
With reconstruction, is it easier to have both breasts removed?
That's a little bit complicated in the sense that there's the issue of if you're having one removed and removing the other at the same time, and you're going to potentially be undergoing chemotherapy or other treatments, having the other one removed could double the chance of an infection and delay treatment. So there's that aspect of it. Coming back later and getting it removed sometimes is an issue with insurance. If you don't have a mutation, then they wouldn't necessarily approve it. So in terms of reconstruction, I think it kind of comes back down to what kind of reconstruction are you having. But some people have found that there is more symmetry when they have both removed.
It would only make sense, I think. Let's talk about immunotherapy. What is that? I hear that word, but I want to understand what it is.
Yes. So immunotherapy, we've been hearing it everywhere for the last couple of years. We've heard it from President Jimmy Carter, who had melanoma, received pembrolizumab, the checkpoint inhibitor, and the tumor melted away. So it's very exciting. Basically, when you think about a cancer, it should be a foreign little body in your body, and your own immune system should kill it off. Yeah. As it does any bacteria or anything else.
When we have a cold or a flu or whatever.
Exactly. That's exactly what should happen, and that's what often happens with cancers in our body. But it turns out that certain cancers basically make a little protein that tells the person's own immune cells, the immune system, that it's not foreign. It tells,
so it's hiding.
It's hiding. And it basically does the same thing that normal cells in the body do. Normal cells in the body produce the same protein so that they aren't killed off by the immune system. And the cancer, which is very tricky, does the same thing. So checkpoint inhibitors of immunotherapy, which is what we're talking about, what they do is they go in and turn off that little protein that tells the immune system to turn off. So it's a double negative. Wow. And it works. It's very exciting because it works. It tells the immune system to go ahead and rev up and attack that cancer cell.
That's amazing. And so, you know, we contribute to all sorts of things, especially, you know, Breast Cancer Awareness Month. There seems like if you buy this, it goes to this. But when we hear it goes to research, that's the kind of things that are happening from all this research.
Exactly. It's amazing. And breast cancer, which usually leads the field in most different types of cancers, is actually a little bit behind with immunotherapy.
Why?
So it was really, well, it's when we think of immune cancers, we really think of melanomas, and then it was sort of developed in lung cancer as well. But in breast cancer, it's really not clear who's going to respond to immunotherapy. So, and the initial studies were not all that exciting, but it turns out that there's probably, again, a subset of breast cancers that are likely to respond to immunotherapy. And it's likely that subset will include triple-negative breast cancers. These are cancers that are more mutated, they have lots more mutations in them, so they can be more easily recognized by the immune system as being foreign. Makes sense. And they also are more likely to express this protein that tells the immune system to turn off. So I think one of the most exciting things is a recent study that looked at immunotherapy in breast cancer, and when you look at it as a whole, it's not all that exciting. But when you look at it more closely, you see that there are 2 or 3 patients in there with triple-negative breast cancer, widely metastatic, who've received multiple lines of treatment, whose cancers have suddenly stopped growing. So there's something about those those patients, and if we can see it in those 2 or 3 patients, we need to figure out what is it about them that makes them respond, and basically generalize it.
Absolutely. Yes. That is exciting. Okay, well, on that note, we're going to take a quick break again. We have one more long segment here, so if you have a question you would like answered, now is the time to call. Go ahead and get on the line, 615-737-PLUS. Stay with us.